pictures in plastic surgery, and so it's kind of a fun, interactive thing. It's not just going to be all didactic, so it'll be hopefully interesting. There will be pictures of surgery, so just a heads up, if you feel squeamish, just look away, but hopefully they're not too graphic. So it'll be a little introduction to plastic and reconstructive surgery, what I did as far as my education, what my day-to-day life is, what type of work I do, and then how I use anatomy and physiology in my daily life, and I use it every day, all day long. And then I will show you those real-life examples. So plastic surgery, you guys have all heard of plastic surgery, I'm sure, social media and internet and everything. So plastic, what makes plastic plastic? It's something that's moldable or shapeable. It's different than wood or other things that are not bendable. And so plastic surgery comes from the word plastic, obviously. And this is from the Webster Dictionary. The process of reconstructing or repairing parts of the body by the transfer of tissue, either in the treatment of injury or for cosmetic reasons. And I think today, as you see the presentation, I think you'll be surprised at what plastic surgery is and what it is not, because the social media aspect of what you see and what I do is very different than my day-to-day life. So it'll be kind of interesting. I think even medical students who are further along in their training than you are very surprised when they come and rotate with me on what we actually do and what we work on. This is just another of the Oxford Dictionary, same thing. Improving the function or appearance of body parts through reconstructive or cosmetic procedures. So this is probably what you guys have seen. I think I dropped out. Maybe the battery's dead? Possible. There's no light on here. Do you want me? Oh, there it is. So a lot of people see what's on TV. Botched is really popular. I get that comment in my clinic all the time. People talk about the Kardashians. Dr. Pimple Popper, I hear that about every day. That's not what I do. So I am a plastic and reconstructive surgeon, and that involves a wide range of, just keeps popping up.
You might have to go without it.
Okay, we'll do it. We'll try. It does involve cosmetic surgery. I do a full complement of cosmetic surgery head to toe, but reconstructive surgery is about 85% of my practice, and that includes craniofacial surgery. If people have heard of cleft lip, cleft palate, craniosynostosis, which means plates in the head that fuse in childhood. Those are all involved in craniofacial surgery. That's usually pediatric plastic surgery. Microsurgery is a large part of what I do too. It's part of my reconstructive surgery. It means I connect blood vessels, tendons, nerves, and repair them under the microscope. So this is involving things like if a finger gets cut off, we can put it back on, and that's microsurgery. And then I actually am fully trained in hand surgery. That's already part of what plastic surgeons do. And it's because of that microsurgery component, because we can repair tendons and nerves that are very, very small caliber. And so we do that actually as much, if not more, than orthopedic surgeons, which most people think of as the hand surgeons. I myself am self-employed, so there's two different ways that doctors can practice. We can either be employed by a hospital or we can be employed by ourselves. So I'm self-employed, but I work with a group of other surgeons and doctors. About 100 of us work together. So we are all in a group together, and of them there are 4 plastic surgeons, and at our clinic we have 20 employees. What does this entail? So you guys are in high school now, so I started right at high school. So after high school, medical school, you do 4 years of college, then 4 years of medical school. And then we train in residency. So people use all these terms and you may not be familiar. So a resident is somebody that's graduated medical school. They are a full doctor, an MD or a DO doctor. And then they have to do specialty training. And this is on-the-job work. So you're actually practicing, taking care of patients, but you're practicing with the guidance of other physicians. So I did that for 6 years for plastic surgery residency, and then I did additional training in reconstructive and cosmetic breast surgery, and that's kind of my subspecialty within it. And so for those of you that are good at math, that's 15 years after high school. So it's quite a long training, but people think like, I don't want to sit in a classroom for 15 years. You're not. So for the first portion of that, for college and medical school, you pay them to teach you. So that's still education. And then the second half of this, you're essentially an apprentice. And you do get a stipend and you do get paid and you work, but you're working under the guidance of other people. So it's not like it feels like you're just sitting in a classroom for 15 years. You're actually up and doing stuff and practicing what you're going to do eventually. So what does my daily life look like? So about half of my time I'm in clinic, and that means that I meet new patients that come in and have problems. I look at those, sometimes I diagnose new problems, and then I tell them how I can fix them. So I meet new patients in the clinic setting, and then after surgery they come back to clinic to have a checkup and make sure everything's healing just right. So that's what I do about half of my time, is take care of patients in my clinic, and this is my office here. I have an office outside of the hospital. Some doctors actually have their offices in the hospital, but we chose to be on the outside. And then this is what I do the other half of the time. I'm somewhere in there. But this is a typical team for a surgery. We usually have a surgeon, a surgical assist, an anesthesia provider that puts the patient to sleep. There's a nurse that just functions full-time in the room to get supplies. And then I also have a nurse practitioner or a PA that usually helps me in the operating room too. So this is what it takes for somebody to have surgery. And then there's something we don't like to talk about a lot, but it's call, which means that as a physician, we're ethically and legally obligated to take care of our patients 24 hours a day. So when I go home at night, I'm still working, and if I choose to be off, I have to have somebody else that's arranged to take care of any of my patients that might come into the emergency department or have calls after hours. And so like this weekend, one of my partners is taking care of all the patients if they have questions. We also have somebody that's always listed to take care of patients that come into the emergency room. So that's part of what it entails. So the hours, when we're in clinic, it's about a normal 8 to 5 kind of job. When we're in the operating room, we usually work for 8 to 10 hours at a time, and then call is typically overnight. But you do that from home in my field, which is kind of nice. So what do we do? What's the scope of what I do? A lot of people know, like, if you're a podiatrist, you take care of feet. But with plastic surgery, there's really nothing I don't take care of. I take care of head to toe for the body parts and all ages. So it's a lot. I think there was something else in the animation there that we might have missed. But basically, everything you can imagine head to toe. So cleft lip and palate, facial bones and facial plates that are fused too early, reconstruction of the skin, that's from trauma or from cancer. I do the cosmetic things you might have heard of, the facelift, neck lift, eye lift, nose, ears. We adjust jaws that are malformed and don't grow properly so that your teeth match up properly, or if you have a jaw fracture, we can repair that. All the other facial fractures from car accidents and falls, facial lacerations and dog bites, that's typically what I take care of in the emergency department at night. We do transplant tissue, so I don't transplant organs other than if you consider the skin and muscle and bone an organ, I do transplant that, and I transplant it sometimes without a blood vessel, and sometimes I have to do actually a blood vessel that I connect as a true transplant. A large part of my practice is breast cancer reconstruction. So after people have mastectomies, I reconstruct the breast, and then the cosmetic breast surgery. So what's good about my job and what's bad? There's the dirt on everything, right? I like my job because I'm a very physical person. I was an athlete, I am into sports, I like being on my feet, I like working with my hands, and that's what I get to do. And I get a lot of variety. There's not a single patient that comes in and has the same problem. If you think about some of the other fields of medicine, like a general surgeon, somebody comes in with their appendix inflamed, there's about 5 steps and they take out an appendix. So it's very similar every time. Somebody that comes in with a skin cancer, it could be anywhere, it could be any size, and it's very different every time. And so I really just have to use principles and kind of make it up as I go, actually. So it's more about learning the physiology and the anatomy of what I can do and then applying it to each problem. So it's kind of interesting every day. It's very interactive, so I get to meet patients in clinic, and then even when I'm in the operating room and my patients are asleep, I have a group of 5 or 6 people that I'm interacting with every day. And I have some ownership of this, so I get to run my practice, I get to kind of dictate how my clinic and how my daily life goes, and I kind of set that up how I want. And I really like my job because I can see the results. When you go into the doctor and they say, your blood pressure is high, and you send them home with the medicine, and then they come back in 3 months and it's the same, and it's just not as satisfying. When I go into the operating room, I see a problem, I fix it, and they leave and it's done. And so that's pretty cool for me. Some of the bad things, I'm on my feet almost every day, all day. So it's very physically demanding. I do have some long days, although I can tell you when you're enjoying what you're doing, it goes pretty fast. So it is something where you're kind of your own sport. So I take care of the patients and I'm ultimately responsible for them. And like I said, when I go home at night, if they have a problem, they call me. But I do have a great support team. So, and then there is a lot of paperwork and computer work with every job, I think, but people don't often think about that with medicine. We do have a lot of forms and things we have to fill out. We have to complete a lot of documents, so that's kind of the less fun. And the ownership, ultimately you're responsible, so. All right, so why am I here today talking to you? You guys all were doing anatomy and physiology, right? So anatomy is basically what I do every day. So I look at what the problem is and I know what the structures are, and then I'm able to use physiology to guide me on how to fix it. So if I didn't know how things would respond and react when I cut them or move them, I wouldn't be able to do my job. And I wouldn't be able to do it effectively and quickly. So by knowing the anatomy very carefully, I can do my surgery and do it very efficiently because I know where I'm going and I know that I'm not going to damage other structures. So if I didn't know where the small nerves were or the blood vessels were, I could cause injury. But knowing that very carefully allows me to do my job well. So here's the fun part. Feel free to stop because these might be confusing, so just ask me if you have any questions. I'm going to talk a little bit about something called a graft, which means taking something from one place of the body and putting it somewhere else. A graft is very thin and can survive just on the underlying surface. So I just need to put it on some healthy tissue, and then that tissue feeds it until it's grown in at that spot. I'm also going to talk about a flap, which is moving a large piece of tissue, like a whole muscle or a bone, and I have to take that with a blood vessel so that it can live there. It can't just survive by absorption of the stuff around it. So that is an example of a skin graft there. So it's a shaved piece of skin. And that's an example of, that one right there is a latissimus muscle. So from your back, that's a latissimus muscle. Up in the top left corner, that's the blood vessel that keeps it alive, and I'm going to hook that up. And that skin is the skin over top of that, and I know I can take out a certain amount and still get the back closed. And I know that unless you're a competitive cross-country skier, you're not going to miss this muscle in your back much. So I have to know what muscles do what and which ones I can steal without you having loss of function. So this muscle doesn't do a whole lot other than this motion right here. So maybe rowers and cross-country skiers might try to avoid that surgery, but for other people I use that pretty commonly. So I've done a lot of facial reconstruction pictures in this just because I don't want to go down into the breasts or the abdomen and get too graphic. So we're going to stick to a lot of the facial reconstruction, but the principles apply anywhere in the body. This is a nice lady who had a skin cancer on her nose. So she showed up with a bandage on her nose and had never seen what's underneath it, but she had had a skin cancer removed earlier that day. And it went through 3 structures: skin, cartilage, and mucosa. So I have to reconstruct all 3 of those things. And when we look at a problem like this, we think about form, that's the appearance. So I want her to look normal, and function. I want her nose to function. It's got to have the bony structure and support and the skin covering so that she can breathe properly. So I have to fix 3 different layers, and I've got a gigantic hole. And when you think about it, it's 3 times that size because I have to replace all the layers. And ideally, I'd want the skin to be the same color, the same texture, the same sun exposure over her life as what she's got there. So I try to find skin that's in the same area, so it's got the same life exposure, so it has the same quality and characteristics. And as we talked about a flap or a graft, I have to have a bed to put a graft on. I don't have a bed, right, because it's just a hole. So I have to do a flap. So in this case, I will do, this is the oldest plastic surgery known to man. So you're gonna see the first plastic surgery that was ever done is this type of surgery. It's called a forehead flap. So I know that the forehead has a lot of skin that I can steal from, and I can get it closed on its own. This is not how she's gonna look in the end, I promise you. So I have skin that looks the same color and consistency, it's the same thickness, and does anybody know there's blood vessels above the eye? So there's two, a supraorbital and a supratrochlear vessel, and based on cadaver studies, I know exactly where those are gonna be. So I can measure out from the middle of her forehead exactly the number of centimeters I need to find that blood vessel, because I'd never be able to see it to my own eye. And I can design a paddle of skin that goes from that vessel all the way to the top of her head. I measure the arc of rotation and know exactly where I need to put that piece. I shape this piece based on, I make a little metal template, a foil template, and I put it up here. And then I basically lift it up and keep that blood vessel hooked up. So the blood vessel is hooked up and it's feeding this tube. And I know based on physiology that in 2 to 3 weeks, your own blood vessels from the nose will grow into that tissue and make it alive without the blood vessel that's hooked up right now. So when I move it over there, new blood vessels grow in. They dilate and they grow into that because they see the demand of the tissue there. And we call that waltzing tissue. Essentially, we can travel it all over the body by the fact that new blood vessels will grow in within a couple weeks. So I took her back to the operating room 2 weeks later, and I want to make this thinner because it was really bulky. So I cut the inside, so that piece is wrapped around. I made the inside and the outside with that. I still have to do the cartilage. Can't forget about that. So I decided to thin both of those, so I separate them out. So there's an incision line right, I hope this is a pointer, right, can you see? I made a cut here. And now the inside is living on its own, and the outside is still living on that blood vessel. But when I did that, I thinned all the fat underneath there, and I slid in a piece of cartilage. And I took the cartilage from the ear, because I know that you're not gonna miss it there. So now I've repaired the cartilage, and then 2 weeks later, I cut that tube off. I put the base of it back here. That middle part got thrown in the garbage, and the edge of it got sewn to there. So now it's living on its own there, and I don't need the blood vessel anymore. And that's where I took the cartilage from, in the back of her ear. You can see you can't even notice it being gone. And I took the skin from the top of her forehead there. And that's what she looks like now. So form and function. So she looks pretty normal, and it's stented open and it doesn't close when she breathes in because she's got that cartilage there. So it's pretty cool. So forehead flap, it's the first plastic surgery that was ever created. And from the side, she's got a normal profile. This is a little boy that had a Weimaraner bite his nose, and we're missing some of it. And in little kids, they don't have a whole lot of extra skin. As we get older, there's some looser stuff, so I might have been able to do something different in an adult. But also on him, he needs more cartilage too. So a very similar procedure, just a very different patient. So this was him when he first showed up to the emergency department. They gave him a little medicine to make him sleepy, and I tried to figure out exactly what we were missing because I wasn't sure exactly when I saw him what all we would need. So they gave him some medicine. I put together this little flap, flipped up, put that together, but we were still missing 3 pieces. So a very similar procedure in this little boy. I know on the forehead, this hole is not a big deal. It's going to close in. So I'm able to take as much tissue as I want, even if I can't close the forehead, because I know that'll work okay. And that's him a couple months after he was done with his procedure. So it works pretty well. People don't like those 2 weeks when they've got that tube down, but in the end, it's worth it. This gentleman has a melanoma right here. And if anybody knows anything about melanoma, it's one of the skin cancers that's actually dangerous as far as it can shorten your lifespan. It can travel other places in your body. And so we treat it very aggressively. I have to take 2 centimeters around this entire little spot, and I have to check his lymph nodes. And from physiology, I know that your blood takes nutrients places, dumps out fluid and nutrients, and then you have essentially the waste products of the body, and they've got to get back to your bloodstream in a filtered fashion. And that's what the lymph nodes do. So the lymph stream takes dirty fluid in your body, filters it through lymph nodes, and then dumps it back into your bloodstream. What happened there? I'm missing this one. That one went out, but I'll look this way. So if I want to know if a skin cancer is traveling, I check those filtration nodes from that area. And I know that in this area, there's 2 places that it might drain to, under the chin and by the ear. So we send him for this study where they inject a nuclear medicine dye here, and then they can see which lymph node lights up, and it just tells us that's where I need to check the lymph node. It's telling us where it drains to. So that is how much I have to take out to know that I'm getting the melanoma out. So it's a huge hole. And I essentially do a reverse facelift on him. And when we think about form and function again, so I try to make the scars in areas that are going to line up with natural creases in your body. So you always have a crease by your mouth here. You always have a crease in front of your ear. And I know I can steal all of this. I know that that skin will stay alive because of the principles of blood flow. I know the width to length ratio that I can keep alive. And so I'm able to lift this skin up, rotate it up. Does anybody see anything problematic here? It's a little dark, right? So the outflow, the veins, are all cut on the top, on the side, and on the side. So all of the veins need to flow out through the bottom. When he's lying flat like this, it looks pretty bad. It looks like this isn't gonna live. When he sits upright, all that blood flow drains out. And so, despite it looking a little bit concerning there, it was okay. And that's how it looks a year later. So you're able to hide the scars in areas that are natural creases. You see the one scar that's not in a natural crease is the one that draws your eye. You don't really pay attention to the stuff here or by his ear because that's kind of where we normally have folds. I can do this for cosmetic reasons too, for a rhinoplasty. I'm able to know exactly where the bony and cartilaginous support is, and I need to keep the nose so that she can breathe properly, but take down some of the extra tissue. And so I really have to understand the airflow dynamics and what portions of the cartilage and bone are holding open the airway, because if I remove that, she won't be able to breathe. So I took off some bone here, some cartilage here, and I actually cut a muscle between the nose and the lip because her lip was too tight. But I knew she didn't need that muscle, and it was actually kind of holding her mouth open. Now, the other thing I do is kind of what I talked about, the transplant surgery. So I can move bone, tendon, muscle, skin, fat. I can move any of those as a transplant of tissue, and I hook up the blood vessels somewhere else. I usually do this for people that have a cancer reconstruction, like a breast cancer. Another example would be a jaw cancer. We can use a whole fibula bone and reconstruct a jaw. We can do this for people that have things like motorcycle or car accidents and they have large open wounds with just bone exposed. You can't put anything on bone because there's no blood flow to heal it in, so you need to actually transfer tissue with a blood vessel. This is a really cool procedure that we do, and everybody knows the abs, the six-pack, right? So there's two big strips. That's what your abs are. They're the rectus abdominis, so that's the RA part in this, rectus abdominis. I can take the muscle and the skin and fat, just like a tummy tuck, or I can turn it up and down or sideways, and I can put it all over the body. We can use it to reconstruct a breast, we can reconstruct the groin area, we can disconnect it and reconstruct a leg. But when I do this for a breast cancer, I have a lot of really young breast cancer patients, and I don't want to take their abs because that's part of their core strength, and it really does limit their function. So I do something called a DIEP flap, this one. So these ones, they're depicting taking the muscle with skin over top of it, and then you lose your abs muscle. This one over here, I'm able to take and spread the muscle apart and take the blood vessel from underneath without ruining the muscle. And I can take the skin and fat of the abdomen, just like a normal tummy tuck, and roll it up and reconstruct it into the breast. And I hook it into the arteries up here. How do I know I can do this? So I know the anatomy of how that blood vessel travels through the muscle. So you have your iliacs, and then you have your inferior epigastric artery that comes up here, and it has a branch lateral and medial. You have the same thing on the top. You have your superior epigastric, lateral and medial, and it travels inside the muscle and then has little branches through it. And so I know exactly where the pathway is, and I'm able to dissect that out and take that without taking the muscle. So this is, it's kind of hard to figure out where you are here. That's the hole where a belly button was. These are those epigastric vessels. This is your abs muscle spread apart a little bit so that I can get that blood vessel out. These blood vessels are about the size of the tip of your pen, so about 3 millimeters. That's me inside of a breast pocket, so that skin is breast skin with no breast in there. And I'm hooking those artery and veins up into the internal mammary arteries, so underneath the ribs. So I actually take out a piece of cartilage and hook it up underneath there, and then it becomes alive up there. And it lives and it shrinks and it grows just like the patient would have had it shrink and grow in its abdomen. I can do this other places, so we often take the anterolateral thigh, which is a big paddle of skin that we can take with the blood vessel. Take a muscle from the inside of the leg often too, the gracilis muscle we steal. And we know that there are certain muscles that have redundant functions. So I'm able to take muscles that you're not going to miss. This was what I was talking about. We can do a jaw reconstruction with the fibula, and we know that you just need your tibia for strength. We do want to keep the lower portion of your fibula for your ankle strength, but we can take that entire chunk of bone and put it up and reconstruct a jaw, and we hook up the blood vessels that way. And we do the same thing all over. Tendons, nerves, there's multiple areas where you figure out that you have extra tendons that are redundant, and you're able to steal some of those to reconstruct. So I have just a bunch of other examples, but that's kind of the basic. Oh, this one's pretty cool. So has anybody ever heard of brachial plexus? Have you guys learned about the brachial plexus yet? So your nerves that come out to take care of your arm and your hand and make it have sensation and motor function are called your brachial plexus. They come out right about here. So they come out from your spinal cord, and it's a big plexus of nerves that goes all the way down your arm. When people have car accidents, or sometimes during birth, a baby can have the neck stretched too far, and it'll rip those nerves and destroy it, and so their arm won't function. We can actually transfer different muscles. We can switch the tendons around. So if you can't flex your arm, we can switch an extender over to a flexor. And we just move the tendon from the front to the back of your arm to try to change the anatomy there. So we're able to use some of the redundancy around the shoulder. We can also do nerve transfers to try to repair some of those nerves. So they use the gracilis flap. Remember I showed the inside of the thigh, the gracilis muscle. They can actually transfer that muscle with its nerve to be a muscle up there if you don't have the nerve or the muscle left. And we can do the same thing in the face, which is what they did in this picture here. they put the gracilis muscle into her face and hooked up the nerve, and now it works like a facial muscle, which is really cool. So, did anybody know that we did that in plastic surgery? No, I don't think so. So, it's pretty cool. So, plastic surgery just means moldable, shapeable, transferable, and the vast majority of plastic surgeons are not plastic surgeons, but plastic and reconstructive surgeons, and this is what we do all day long. Is there any questions? It's a lot. It's a broad topic. Yeah?
What's your favorite kind of plastic surgery to do?
My favorite kind of plastic surgery, the thing I like most and do most often actually is a breast reduction. I usually take off, the average breast reduction is about 2 pounds off people's chest, but I've taken, the highest one I took off is 20 pounds of breast tissue off one person's chest. And that's life-changing. I mean, you don't think about it much, but if you had 20 pounds hanging around your neck every day, that's a lot. And it's life-changing for those people. So they're all really happy and they have very little pain. Yes?
How much do you get paid?
That's a good question. So plastic surgeons make a wide variety of pay. Typically, if you go into the medical field, pay for any kind of doctor starts somewhere in the 200,000 range, and then the top end is kind of variable. I would say the average plastic surgery salary is somewhere around 300 to 600,000. But you work a lot, and it's 15 years of education. So yeah, yes.
Did you go to college and medical school?
Yeah, so I'm from central Wisconsin. So I went to college at Marquette University in Milwaukee, and then I went to medical school in downtown Detroit at Wayne State. And then my residency, that training where you're kind of doing the apprenticeship, that 6 years was in Milwaukee again at Froedtert Hospital. And then I did my fellowship in Grand Rapids, Michigan. So a little bit everywhere. Yeah.
What are the risks for patients from surgeries?
There's, every surgery kind of has its own risk, but the biggest thing is damage to adjacent structures. So anatomy is really key. Knowing where everything is, I have to have a roadmap in my mind, just like you have to know where you're going when you get out in your car and go down the road. You kind of have to have an idea of where you're going. And a lot of where I'm going, I can't see the structures. I can't see the nerves underneath the skin. I can't see the vessels. So I have to know where they are. And so I really have to understand the anatomy and make sure that I'm not going to damage the patient more than I'm going to help them. So it's a big key. The other thing is the physiology of this, understanding that I'm not going to lose my reconstruction. I have to be confident that I know what's going to happen in this tissue when I move it, so that I don't lose it and start from scratch and have 2 spots. Now the place that I took something from and the place that I'm trying to reconstruct are now a problem. So really just understanding what I can damage and knowing not to do that. That's the biggest thing. Anyone else? Yeah?
How do you feel like the TV shows like kind of structure their job?
Yeah.
How do you feel like they?
I think it gives people a really skewed impression. I almost feel like there should be a separate term called cosmetic surgeon for those people that just practice cosmetic surgery, because it really is a much different field. Some of the principles are the same, and I do cosmetic surgery as part of what I do, but I think people have no idea the rest of what I do. I can admit this, I didn't have any idea what plastic surgeons did even when I was in medical school, until I accidentally was on a rotation in plastic surgery, and it was mind-blowing, because there's really nothing we don't do. But yeah, it really gives us a bad name. I hear pimple popper at least a dozen times a week, so that's fun. Yeah?
Is there any like surgeries you have to say no to?
Yes, definitely. I do definitely have some cosmetic patients that come in with unrealistic expectations. They want things that aren't really reasonable. So I do have people that I just say, this is probably not the right thing for us. There are people that are just not healthy enough for surgery. I have people that come in for a variety of surgeries. They're not absolutely essential for them to have that surgery, and they're just not healthy enough to have it. And so I do have to sometimes have those conversations with them. Sometimes it involves me telling people, you know, you have to lose 20 pounds and then come back, or you have to stop smoking. That's the other thing, physiology. If somebody's smoking, I'm not gonna do surgery on them unless it's emergent, because I know that their blood vessels are gonna tighten up. And what I do, as I've kind of described, it's all based on blood flow. And if the blood vessels tighten up, it's the same as a heart attack, but it's a heart attack to that skin or tissue that I'm moving. So we do have people have smoking cessation programs, and they have to test negative to have surgeries. Yeah.
So when you were talking about the forehead flap, you mentioned like you measured in centimeters. Is that just like a preference, or is that just always how you learn?
Everything in medical goes in centimeters, and the reason is that you know, it just converts by tens rather than atypical, you know, uneven units. So everything medical always is in centimeters. So we think in centimeters. I can see in centimeters. I know how many centimeters each of my fingers is, because I have to look at things and know things in centimeters. So we always function in centimeters and communicate that way. It's very American that we all do inches here, but it doesn't convert well, and so the medical field uses centimeters. And we use kilograms too. We all use kilograms. So I always grill all the medical students, because we do have medical students that work with us. I always make them convert all of the kilograms to pounds every time we do stuff. I have them hold the tissue when we take it off, and then they have to guess. So it's a fun game for us. What else? Anything else? Yeah.
So obviously you have a very demanding job. There's a lot of pressure involved with that. So can you just talk, I guess my question's twofold. How do you deal with the pressure of being a surgeon, and then can you also talk through work-life balance with you being so busy?
Mm-hmm. So I think to do surgery, there has to be a bit of confidence in your education. You have to know your anatomy. You have to know your physiology. You have to know what you can do and what you can't do, because otherwise I don't think that you could ethically be able to go in and cut a human, because you'd have to know that you're doing the right thing. So I think that really dealing with the stress is really preparing yourself. I don't stop learning. I learn continuously. Every night before I go to surgery, I have a game plan for the next day. I know what surgeries I'm doing. Even if I've done 100 of that, I know what's different about this patient. And so I prepare myself and make sure that I'm ready for the day, because unexpected things come up, and so you have to prepare for what you can. So really the demands of that, just preparation and slow and steady and do what you can. Work-life balance, it's, I think, setting realistic expectations. There's a term in plastic surgery, undersell, overproduce. So I never promise things that I don't think I can keep. I try to make sure my family understands that I'm working late tonight. I'll get there when I do. I don't promise to be home earlier, and then when I get home early, it's a happy day instead of disappointment when I'm home late. So I think that helps a lot in my relationships and just having a family life. I also make sure to have a lot of support. So I have a very good support team as far as my husband understands my job and takes care of a lot of stuff that I can't. And then I have really, really great nanny and sitters and stuff that make sure that I can get to what I can get to, and the children can kind of get where they need to go without feeling my work schedule. So I'm in the privileged place of being self-employed, so I can actually set my schedule. So I see my kids' games, I go to my kids', you know, concerts and stuff. But that's a privilege because I did choose to be self-employed. So, yeah.
Have you ever gotten plastic surgery yourself?
Yes, for sure. We always have devices and things we're trying out at the office. I've done the Cool Sculpt fat freezing machine. I get Botox and all those things. It's super fun. And we have a spa in my office, which is one of the really cool perks of having a plastic surgery office, is because I do have estheticians that do facials and kind of fun things like that. So it's kind of a fun part of my practice, but yeah. Mm-hmm.
Student council members, remember to go to Mrs. Hillstrom's room during advisory. Student council members, go to Mrs. Hillstrom's room.
When you're on call, can you go in the middle of the night or whatever, do you ever have to do like an emergency surgery?
I sure do. So most commonly the things I get called in my practice, fractures and lacerations from car accidents or falls, dog bites, usually little kids with dog bites on the face. I get called in for a lot of those. I used to cover hand surgery call too, so if people, you know, used a table saw and cut into their finger or fell and broke their hand, I used to cover that, but I've just kind of limited my practice. I'm not doing much hand surgery anymore. We do, you know, facial fractures. We sometimes have to plate different facial fractures, reduce nasal bone fractures, you know, when the nose gets sent to the side. So some of those I have to do in the middle of the night. Some of those I can just see them in my clinic and schedule them in the operating room. So it's not too bad. Yeah.
I'm just like, what is the youngest age you have to do any sort of, like, plastic surgery?
The things that I see kids for, I do see kids at a very young age. We often will take off extra digits, so duplicated thumbs or pinky fingers, we'll take those off because that kind of goes right in that intermediate between hand surgery and plastic surgery. It really does fall into our field. We do have congenital nevi, which are moles that can become cancerous that some kids get early in life, and we'll take those off. Sometimes they're extremely large, so we have to do them in different stages and expand extra tissue for that. So some of those kids see us as early as like the day after they're born because the patients want to talk, or the parents want to talk to us about it. Usually we try to limit surgery to at least 3 months old. So cleft lips we do at 3 months old because that's helpful for them to get it as soon as possible.
Please go to the Commons. Alex Yoder, please go to the Commons.
We want them to be able to eat and function, to be able to nurse properly. So they have some prosthetics they can use and some dripping feeding tubes and stuff before then, but we try to get cleft lips in at 3 months. And they have to be about 10 kilograms. And then cleft palates are done at 1.5 years. Congenital nevi and hemangiomas, which are little blood vessel clusters, we typically try to wait till they're about 1 year if possible. If they grow rapidly, we might have to do them sooner though. So those are kind of the younger patients typically. We see some kids with trigger fingers. It's kind of a congenital thing, so we do little trigger finger releases.